Hello, everyone, and welcome. We're so excited to have you all here today. We are going to wait a couple minutes for a few more people to join us. And my name is Jessica Reed, and on behalf of the Maine Lung Cancer Coalition, in partnership with our organization, the Maine Medical Center Center for Quality Improvement, we are again very excited to have you all here today for Destigmatizing Lung Cancer, a theory-based approach to public health messaging. Again, we're just going to wait a couple of minutes, maybe 1 minute or so, and then we'll get started. Okay, everyone, we're going to get started again. I'd like to welcome you all today. And again, my name, for those that have recently joined, my name is Jessica Reed. I'm the Clinical Quality Manager for the Maine Medical Association Center for Quality Improvement. And we are so excited to have you all here today for the next in our series on behalf of the Maine Lung Cancer Coalition, Destigmatizing Lung Cancer, a theory-based approach to public health messaging. Our speakers today, we're so excited again that they can join us as well. Liz Charnetsky, she is the research coordinator at the Center for Outcomes Research and Evaluation for Maine Medical Center Research Institute. We also have Leo Waterston. He's a program director for the Center for Outcomes Research and Evaluation, Maine Medical Center for Research Institute. And Dr. Paul Hahn, a senior scientist for the Division of Cancer Control and Population Sciences from the National Cancer Institute. Liz, you could advance the slide, please. So we just have a few housekeeping slides that I'm going to run through, and then I will turn this over to Liz. So as always, we are so grateful for our funders, and we would like to thank the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, the Maine Economic Improvement Fund, and Anthem Blue Cross Blue Shield, without which this would not be possible. So we are very grateful. Thank you. Some important webinar notes. You are in listen-only mode. Please use the chat feature if you have any questions or want to make any comments during the presentation. We will be monitoring those questions and we will be saving those to the end of the presentation. We have 3 presenters and, sharing screens and things like that. It makes sense to do that at the end. If we do not have time to answer all the questions, we will develop a question and answer document. We will send that to our presenters based on what's ever in the chat. And then we will send that out to all the participants. So please know that all your questions will be answered, even if we don't get to them during the time that we have. The video screen size and location is adjustable by clicking in the top corner of the boxes and dragging. If you're joining by phone with others on the same computer, it's important that you enter the information to the chat window and or send your name and email to marymilam@mainemed.com. And that's for CME purposes. Next slide. And rolling right into CME. So disclosure, today's speakers do not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in the CME activity. The CME will be available for participants who have signed into the live webinar. If there are multiple people, again, at one computer, please type their names and addresses into the chat box for our attendance records. We do not have separate nursing CEUs, but you can certainly get a CME certificate. Once the webinar is ended, you will get a pop-up on your screen that will direct you to the survey. If you leave the meeting before that happens, contact, again, marymilam@mainemed.com, and please complete the survey via SurveyMonkey within 2 weeks, and we will send out a reminder after about a week as well. What's really nice about this process is that you'll be immediately able to download your CME certificate on the last page of the survey. If you have any difficulty with that, again, please let Mary know. Next slide, please. So today for our learning objectives, we're going to understand stigma as a psychological concept. We're going to understand ways in which stigma and implicit bias impact individuals with lung cancer. And third, understand how social psychological theory can be applied to public health messaging to motivate the general public to engage in risk-reducing behaviors. Next slide. So at this point, I would like to introduce our speakers. Our first speaker today is going to be Liz Charnetsky. She is a research coordinator, as I mentioned before, at the Research for Outcomes and Center for Outcomes Research and Evaluation, CORE, at Maine Medical Center Research Institute. She completed her PhD in experimental social psychology at the University of Vermont, and her research interest lies in understanding how stigma and identity threat impact the delivery and recipient of healthcare. For sake of time, I will let you all read the rest of that. Welcome, Liz. Next slide, please. I'd also like to welcome Leo Waterston. He's the program director for the Center for Outcomes Research and Evaluation for CORE, again, Maine Medical Research Institute, where he is responsible for the center's operations, strategic planning, and management of staff and resources to support CORE's mission. He also serves as a project director for the Maine Lung Cancer Coalition, which is, again, this organization presenting this webinar, a grant-funded lung cancer prevention and screening program with partners throughout the state of Maine. And I'll let you finish that, reading that slide later. Next one. Welcome, Leo. We're also very excited to have Paul Hahn here with us today. He is a senior scientist in the Division of Cancer Control and Population Sciences and the adjunct investigator in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute. Dr. Hahn's research focuses on understanding and improving the communication and management of uncertainty in healthcare, and his work has examined clinical problems in cancer care, genomic medicine, and palliative and end-of-life care. So again, we are so excited to have all of them here with you today, and this time I'm going to hand this over to Liz to take control of the slides and continue forward. So Liz, I'm going to hand it over to you.
Thank you so much for having me. Let's see, I'm going to try to make my screen behave. Sorry about that. All right, so thank you so much for having us join you today. My name is Liz Charnetsky, and I'm joined by Leo Waterston and Paul Hahn. And on behalf of the team at the Maine Lung Cancer Coalition, we're going to be speaking today about lung cancer stigma, and more specifically, how we can use social psychological theory to help mitigate some of the negative consequences that are associated with stigmatization. Another big thank you to our funders. We can never thank them enough. Bristol Myers Squibb Foundation, Maine Cancer Foundation, Maine Economic Improvement Fund, and Anthem. Another brief disclaimer that the opinions that we are speaking about today are our own and do not represent any of the other agencies or institutions listed here, and that we have no other conflicts of interest to disclose. So today we're going to start off broad by discussing what implicit bias is and how it can give rise to phenomena like stereotyping and stigmatization. And then we'll discuss lung cancer stigma more specifically and wrap up by speaking about how social psychological theory provides a really promising avenue for mitigating some of the stigmatization of lung cancer. All right, so I wanted to start out today at the offset by really acknowledging an important point, which is that we all walk in the world with bias, in part because of how our cognitive systems are structured, which we're going to talk about in a few slides, but also because we are social creatures, and aspects of our social world, our societies, our culture reinforce how easy it is and how convenient it is to act on our hardwired cognitions. And in fact, Jennifer Eberhardt, who is a leading expert in the study of bias, says that implicit bias is a kind of distorting lens that's a product of both the architecture of our brain and the disparities in our society. So bias really works as a self-perpetuating cycle, hardwired in our cognitive systems and reinforced by the larger social structures that we partake in. So while I think it's really important to acknowledge that we all have bias, I also think that it's important to say that it's something that we should not be complacent about. And in fact, what social psychological research has shown is that one of the best things that we can do to mitigate bias and some of the stigma that results from bias is to recognize that we're not immune. And it's through that kind of awareness and mindfulness that we're able to put the brakes on the cycle. If we understand how bias and stigma operate, we can recognize the situational contextual triggers or the environments in which we might be most likely to use cognitive shortcuts. Spoiler alert to some of our later conversation, situations like healthcare where uncertainty is high and available resources are low might be times in which we are really likely to rely on those kind of pure, easy, hardwired cognitions. So it's through mindfulness and awareness that we're able to actively work on our responses to situations that are likely to evoke bias. Okay, so I wanted to jump off by speaking about attitudes. And attitudes are just our evaluations of people, objects, social groups, events, and ideas. And I wanted to start off by speaking about attitudes because they are considered the foundational component of our cognitive structures. At the most basic level, we have to be able to navigate our social world. And to be able to do that, we need to create a baseline evaluation of how we feel about things. Is what I am encountering good? Do I feel good about it? Or is it bad? More complex cognitions can follow that kind of initial assessment or evaluation, but really nothing can come before that really primitive affective evaluation of something. If we're able to determine our baseline feelings of the things we encounter, or rather if we were not able to, I always say that we'd be stuck all day brushing our teeth. So how does it work? What we do is we create mental representations for everything that we encounter in our world. I'm sure you've seen those memes that kind of have the old phrenology type of image where the brain is segmented into portions, right? And it's like puppies, pizza, candy. And while these are really funny, they're actually a pretty good representation of what happens. What we do is we form an opinion of whatever we encounter and determine whether we like or dislike it. And that becomes the foundation of our cognitions. So the core of our representations is how we feel about things, good or bad. And even if it is subconscious, these are the primary drivers of our behavior. Whether we feel good or bad about something is ultimately going to dictate how we behave towards the things that we've mentally represented when we do encounter them. We really aren't able to make decisions on how to behave towards things very easily unless we have these kinds of attitudes. So bias is actually considered a type of attitude. It's typically considered a negative evaluation, or if not negative, a preference for one thing over and above another thing. And biases can be explicitly manifested or implicitly manifested. When we talk about an implicit attitude, what we mean is that we are not only unaware that we hold this kind of evaluation, or we're mistaken about the nature in which it has been constructed. So an implicit bias is when we have an attitude towards people or associate stereotypes with them without any kind of conscientious or conscious knowledge of doing so. An explicit bias or an explicit attitude, in contrast, is when we're consciously aware not only of our evaluation of them, but also how it is then enacted. And this is really how bias can be related to things like prejudice, a more overt action. Prejudice is when you direct those negative attitudes or feelings at others strictly because of their membership in a particular group. And biases, implicit included, can give rise to an experience of stigma or stigmatization, which we'll speak more about. But in essence, stigmatization is being persistently stereotyped or devalued in society because you belong to a particular social group or you possess a particular quality or characteristic. I always say that our cognitive systems in general are designed for speed, not accuracy, and attitudes are no exception. They're designed to make our life easy for cognitive simplicity. Again, we are hardwired to be able to create attitudes so that we can have that foundational mental representation from which we can act. But that being said, we have a lot of cognitive shortcuts that we use when we are forming attitudes. Attitudes are formed automatically. We have no cognitive control over whether or not we make attitudes, but we do have cognitive control over the kind of content that informs our attitudes. Some of the primary ways that we create attitudes or the information that goes into them are our experiences, so firsthand lived experience, our exposure to different things in our environment, and also formalized education. It's really important that we have attitudes, even though they're typically made for speed, not accuracy, because they take us from point A to point B without a whole lot of cognitive effort. And this is where mindfulness and awareness becomes really important, because we're able to identify situations in which we might be likely to enact an attitude that's based or rooted in a cognitive shortcut. And I'm going to highlight a couple of common cognitive shortcuts in the next couple of slides, but I will say that it is a non-exhaustive list. So there are many others. So the first one that I wanted to speak about is the availability heuristic or the availability bias. And this is a cognitive shortcut in which we form an attitude about something on the basis of whatever information is most readily available to us or whatever is most salient, maybe in our larger social environment, as opposed to really examining probabilities or other possible alternative explanations. So a classic example from Tversky and Kahneman are people's attitudes about plane safety, for example. We hear about each and every time a plane crashes. But on the flip side, we never hear about each and every time a plane safely takes off and lands. So therefore, we can overgeneralize the degree to which maybe flying in a plane is unsafe, which creates a problematic and inaccurate evaluation of planes. Translating to a more social example, the association between smoking and lung cancer. Examples of these kinds of cases are much more readily available and publicized than some of the other alternative risk factors that can lead to similar outcomes. Another cognitive shortcut, the representativeness heuristic or representativeness bias, is in which people draw on their past experiences to make probabilistic evaluations. So they determine how similar or different something is, a person or a situation, to something that they've previously encountered. This is a really powerful driver of our behavior, and it's important that we're able to do this, to be able to draw on our past experiences to change our behavior and adapt to what we've learned. Otherwise, we'd be like the individual from Memento, which I was recently told by my students is a very outdated example, but it would be pretty crippling not to be able to use our past experiences to guide our behavior. A classic example, again, from Kahneman and Tversky, is to think about the features that are representative of a particular group or category. And in this case, they used bird. When we think about the category bird, what kind of features come to mind? That based on our past experiences and exposure to birds. We typically think about them flying, having wings, something comes to mind like a finch or a robin. We don't oftentimes think about exemplars that might be atypical, like a penguin, a bird that swims. Where this kind of heuristic goes wrong is that just because something isn't prototypical or has a quality that maybe is more indicative of another group or category, like a fish over a bird, doesn't mean that it's not a deserving member of that group or instance. So are swimming birds any less of a bird? So we can quickly go into the path of dehumanizing a particular instance or group or creating deviant subgroups. And then the last cognitive heuristic that I wanted to speak about is confirmation bias. And this is the tendency for people to especially attenuate to and interpret information that is consistent with their already existing belief systems. So it's hard work once we've made all of those mental representations to rearrange our cognitive schemas. We really don't often do it. So information that confirms our beliefs is given priority, at least perceptively, in how we allocate our attention and our cognitive resources. It's overvalued in our perceptive processes, but also in our decision making. So very related to attitudes and cognitive shortcuts is stereotyping. And stereotypes are considered the beliefs about the common or typical characteristics that social groups have. Social psychologists typically think about stereotypes as the byproduct of categorization, which is just the process of grouping things together. And just like forming attitudes, categorization is universal. We all do it. It's automatic and we can't control it. It's also very necessary. It facilitates cognitive economy and efficiency. If we weren't able to group together similar things, it would be a pretty confusing world. So making judgments of similarity and difference is important on a basic cognitive level, and categorization allows individuals to make predictions and inferences about objects and people very quickly and easily. The problem is that categories are already really oversimplified versions of reality, and over-reliance on them and a lack of mindfulness can lead to generalizations. And that's exactly what stereotypes are. They're culturally and socially specific kind of categorization. When we stereotype, we are using overgeneralizations to make judgments about not only what groups people belong in, but also what kind of behaviors they should be enacting. Stereotypes are very context specific, I will say. So the other thing is they are greatly informed by our social norms, our overarching larger social structures in our culture. And just like bias, one of the primary negative consequences of overutilizing cognitive shortcuts like categorization and evoking stereotypes is that they can give rise to stigma. And targets of stereotypes often experience stigmatization. So stigma is considered a mark of disgrace that is associated with a particular characteristic, quality, experience, or identity that is devalued within a particular context, society, culture. So again, stereotyping and stigmatization are very situationally and contextually grounded. We typically consider stigmatization as the experiential component of stigma. So when someone has a quality or characteristic, or they belong to a group that has been marked by a stigma, they experience stigmatization, which is typically associated with experiences of prejudice, right? The transfer of all those negative attitudes and feelings on the basis of having this quality or characteristic. They can also experience discrimination. It could be exclusion of an individual, things like that. And then kind of giving another spoiler to our later conversation, for individuals with a stigmatized health condition, for example, these kinds of experiences of discrimination, which can include rejection or societal devaluation, can lead to the internalized belief that they're to blame for their stigma or their illness. And those feelings of shame and blame can impede our optimal health care. And Leo will be speaking more about this. All right, so we know that stigma and stereotypes drive the kind of judgments that we make, which is how we make sense of our world. And one way that we do that is by making attributions. So attributions are very simply the explanations that we create for why events or behaviors happen. And just like stereotypes, they're informed by our social norms, our biases, our stereotypes, and also our attitudes, which may or may not be stigmatizing. And it's highly susceptible then to bias. Socially relevant attribution that we've been hearing a lot about right now might be something like the justification for police brutality is that an individual looked suspicious. The idea that it's embedded in our social context. So attributions are really powerful drivers of behavior. And in fact, social psychologists typically consider attributions to be the antecedent to discrimination. So it really, if we take our attitudes, our biases, our cognitive shortcuts, and create an explanation for why someone is acting and behaving the way they are, it's going to dictate ultimately how we behave or respond towards them, which may or may not be in a way that is discriminatory. So it turns out, just like all other cognitive shortcuts, we're not great at making very equitable attributions. Typically, there are two different dimensions of attributions that we can make. We can make a personal attribution or a situational attribution. A personal attribution is one in which you justify a behavior by evoking internal characteristics of somebody. So, you know, I was late to class because I really hate the topic and I think the professor is boring. I'll be making a personal attribution about the situation or about my behavior. A situational attribution is one in which you evoke situational factors to explain somebody's behavior. And typically, when we are explaining our own behavior, we really tend to emphasize situational factors. So it's not really something about us, it's something about the environment that has created the context for us to behave the way that we did. On the flip side, when we are explaining other people's behavior, we overemphasize personal characteristics or attributions about an individual, which can also give rise to bias. The good news, though, about attributions, unlike attitudes, which are kind of considered more difficult to change because they're so cognitively foundational, attributions can be changed with practice and mindfulness. So over time, we can change our behavior. If we can change our behavior, we can change our attitudes. So you can think of attitudes as a really primary cognitive foundation. It predicts those super primal and initial behaviors, good and bad. Our stereotypes provide the social context. Attributions create meaning for the context and drive our future behavior, which in some cases can be discriminatory or perpetuate certain kinds of disparities. And this is a linear process, or it's depicted as a linear process here, but I will say that all these mechanisms can work to reinforce each other as well. I am actually going to hand things off then to Leo to speak about lung cancer stigma more specifically.
Thank you, Liz, and hello, everyone. So I'm going to talk about lung cancer stigma. And let me see if I can advance the slides here. Here we go. So I'm going to start off with this old anti-tobacco ad, which you've probably all seen ads like this. And this is an example of a hard-hitting sort of anti-tobacco public health campaign. And those types of campaigns that are done with fear-arousing messaging and imagery like this have been shown to be an effective type of anti-tobacco public health communication intervention. But they can have the unintended consequence of stigmatizing those with smoking-related illnesses. So that can lead to stigmatization of health conditions like lung cancer. And if you think back to the process that Liz was just outlining with attitudes, stereotypes, and stigma leading to attributions and then discrimination, that can be at play with imagery and messaging like this. So I'm going to talk briefly about the psychological consequences of lung cancer stigma. And so lung cancer stigma affects how patients are perceived by others, or perceived stigma. So for example, my coworkers don't want to hang out with me because I smoke. It can affect how patients feel about themselves, or internalized stigma. So for example, I've done this to myself, and I've got myself to blame. How patients are treated or expect to be treated, enacted or anticipated stigma. So for example, a patient being asked repeatedly, why are you still smoking? Why do you keep smoking, by their healthcare provider? And how patients talk about their identity or condition with others, or constrained disclosure. And this can all affect an individual's psychological well-being and quality of life. So when we think about the behavioral consequences of lung cancer stigma, it can lead to poor patient-provider communication, delayed detection and treatment of cancer, and poor treatment adherence. Stigma has been identified as actually one of the most prominent barriers to equity in the detection and treatment of lung cancer, and there is evidence in the research literature to back that up. And as part of our coalition, our team conducted a focus group study with rural low-income residents of Maine who are at the highest risk of developing lung cancer due to the high smoking rates in that population. And to understand the prevalence and experiences of stigma among this population, our team, led by a team at the University of Southern Maine, held focus groups with current and former smokers who identified as being disengaged from the healthcare system in 3 rural Maine counties that have a high burden of lung cancer. And in general, the participants in this focus group study described coping with tobacco addiction as a painful experience. And I wanted to highlight a few key quotes from the actual focus groups that point to some of the concepts we're talking about today. So this one, pointing to stigmatization experienced by these participants: it makes it horrible when you walk down the street and you feel like you don't belong there because you're smoking. Physician stigmatizing attitudes also came up repeatedly in this study. So to have them almost look down at their nose at you because you smoked is not right. I don't like that. And a lot of the emergency room doctors are that way. A failure to recognize tobacco use as an addiction. They get you hooked and then they throw you out in the cold. And a sense of fatalism and or nihilism. I know this is stupid, but I think maybe I'll just accept dying rather than having to go through the pain of quitting, because it's like it's never going to be over. So that really gives you some of the sense of what this population, who's really our target population for the Maine Lung Cancer Coalition, is experiencing as it relates to interacting with the healthcare system as individuals who smoke and who are at high risk of lung cancer. So our focus group study illuminated the importance really of the therapeutic alliance between patients and their healthcare providers. And so another objective of our program of stigma research is to understand the prevalence of and factors associated with healthcare providers stigmatizing attitudes towards people who smoke. And so past research on lung cancer stigma has actually almost exclusively focused on patients as the targets of stigma, rather than healthcare providers who may represent a potential source of stigma. So to address that knowledge gap, our team developed what we call the Smoking Stigma Scale for Physicians, or the SSSP, because past research has not attempted to measure the stigmatizing attitudes of healthcare providers, which of course has important implications for improving the quality of healthcare that patients with lung cancers and other stigmatized conditions receive. And so our research team developed this new 11-item self-report measure of physician stigmatizing attitudes towards people who smoke. And we administered this measure to a convenient sample of 118 primary care physicians in Maine. And the response scale for these 11 items that you see here ranged from 1, strongly disagree, to 5, strongly agree. And the measure did show high internal consistency. So I'm just going to highlight some key findings from this survey study. Overall, physicians reported a moderate level of stigmatizing attitudes towards people who smoke, with a mean score of 2.36 on a 1 to 5 scale, with higher scores indicating higher levels of stigmatizing attitudes. And stigmatizing attitudes were associated with physician gender and age, but not with physician specialty. So we looked at family medicine versus internal medicine. And stigmatizing attitudes were significantly higher, as you can see from this bar graph, for male physicians than female physicians, and that difference was statistically significant. And that does unfortunately track with some of the findings in related lines of research, for example, the substance use disorder literature. And stigmatizing attitudes, higher stigmatizing attitudes, were associated with lower perceived self-efficacy in providing tobacco treatment and smoking cessation counseling. As you can see from the graph here, we did not find an association with higher stigmatizing attitudes and intent to engage patients in lung cancer screening. There was also a trend towards an association between higher stigmatizing attitudes and lower perceived self-efficacy in conducting shared decision-making counseling for lung cancer screening. That was not statistically significant, but trending towards significance. So I want to really highlight this finding here that we feel like is a key finding, which is this association between higher stigmatizing attitudes and lower perceived self-efficacy in providing tobacco treatment, which really points to what we were talking about earlier in terms of an effect on the quality of care that these patients receive and health outcomes in this patient population, which is particularly vulnerable and at high risk. So with that, I'm going to turn it over to Paul.
Okay, great. I think I got it here. So good afternoon, everyone. And I'm just gonna really build on some of the comments and the concepts that both Leo and Liz talked about. And after all, the problem facing us really is to understand not only the sources of where stigma comes from, particularly with respect to lung cancer and patients at risk, people at risk for lung cancer, but what we can do about it and how we can actually lower those stigmatizing attitudes and lower perceived stigma, and in a way, in a sense, destigmatize lung cancer. So that's what I want to talk about. So the question is, can we actually destigmatize lung cancer? Can we actually change the way that both providers as well as lay persons at risk for lung cancer, as well as lung cancer patients, and we haven't really talked too much about the stigma that they experience, people with lung cancer. But what can we do about this? Is this really a problem that's fundamentally intractable, or is there a way that we can actually make a difference and try to decrease the stigma that exists around lung cancer and lung cancer risk? we think that fundamentally this is a moral imperative. We've shown you some evidence from psychological science about what gives rise to stigma. We talked about some of the effects of stigma, on people who are actually trying to receive care to prevent lung cancer and also to treat it. But fundamentally, this is a moral imperative. It's a moral question and a problem, and it's imperative that we do something about it. And I think that no matter what specialty we're representing, what people we might be concerned about, stigmatization is fundamentally wrong from a moral standpoint. And we really need to do something about it and to figure out what are the best strategies to use to deal with it. The problem, as Liz went through very well, is that this is basically a psychological challenge, however. We can recognize that we need to do something about stigma. The problem is it's really baked into our nervous systems. In some ways, as Liz was recognizing, it's just part of how we deal with the world. We have to categorize, we have to sort of make quick decisions and judgments every moment of our lives. And so these biases that we all carry around with us have a fundamentally adaptive purpose, and that's why they actually exist. The problem is they also mislead us and they cause us to stereotype others and to stigmatize them. So we have to try to do something about that problem. Unfortunately, there's no really solid proven methods yet to sort of destigmatize or remove these types of attitudes or hold them in check. So what we want to do is to try to find a balance where we're actually using biases in an adaptive way, but we're not going to the extreme of experiencing and perpetuating harms from these biases that we really need to live. So that to me is the fundamental tension and the challenge with all of this. We know that biases are an inherent part of cognition and of basically living a life, but how can we actually be more conscious of them? And also, when we know that they're having bad effects, as in healthcare, can we do something about it and prevent these bad effects from happening? So I think that, and basically what I'm going to show you now is some of our forays, and I think some early work that we've done that we think is promising, where we've actually tried to use insights from psychological science to design better messaging strategies that might help us to actually destigmatize lung cancer. And I'm going to show you a little bit of some work now that we think is promising. So there's actually a couple projects that I'm going to talk about. The first was actually focused on COVID-19 and not on lung cancer risk, but we think that this gave us, obviously COVID-19 is an unprecedented health problem that we're all still living through as a community, as a society. And it also gave us an opportunity to test some of these strategies that we've been thinking about for a while in the lung cancer space. And I want to just show you some preliminary evidence that we got from a study that focused on COVID-19, which we conducted last year. And then we just now, very recently, used similar principles and approaches to try to tackle stigma in the lung cancer risk area. And I'm going to show you some preliminary evidence from that, although we haven't actually finished the analysis of that data yet. What we tried to do in both studies were to design health promotion strategies that can actually destigmatize certain diseases and risk factors. So in the first case, COVID-19, in the second case, lung cancer. And what we did was we tried to use principles and scientific knowledge of these different distinct cognitive biases that Liz reviewed to both reduce victim blaming, this tendency to misattribute personal responsibility to people who suffer from particular conditions or engage in high-risk behaviors, and also to acknowledge uncertainty about health outcomes. And this gets to the principle that even though risk factors are attached to certain diseases and health conditions that are undesirable, we know that there's still always an element of randomness in the world, that even if somebody does smoke, even if someone does engage in high risk behaviors, there's not necessarily a one-to-one correlation with that behavior and the illness. And lung cancer is a case in point. There are many people who might smoke who don't get lung cancer, and there's greater attention to that phenomenon. And by the same token, we know that tobacco use is an addiction. So blaming the victim rather than acknowledging the uncertainties around these phenomena is really not even scientifically justified. So we tried to think about those types of cognitive biases in designing specific informational messaging strategies that might sort of neutralize those biases, to tackle them by undoing them. And we wanted to compare the effectiveness of these different risk-reducing messages to sort of conventional messaging approaches. So in the first study that we did, which examined COVID-19 risk, this was carried out at I was about to say the height of the pandemic, but as we all know, it's been ebbing and flowing even now. But this was back in the spring of 2020. And we looked at how can we message certain risk-reducing behaviors that were being widely recommended by the CDC and other professional organizations. And if you look at the left-hand side of this slide, you can see you'll all recognize these health messages. They're fairly straightforward, and we've heard a lot about these that were instituted around the time of the initial lockdowns. And we chose behaviors that ran the spectrum of things that probably most people would agree with, like washing your hands, watching out for COVID symptoms, all the way to things like, as we know, wearing a mask in public, which has become a really huge source of controversy. But we wanted to sample a spectrum of different behaviors, and then we tested different ways of messaging these behaviors. So we developed additional messages to accompany those recommendations. So for all 6 of these behaviors on the left-hand side of the panel, we paired them with different accompanying messages that were meant to frame these behaviors in different ways, in different, for example, destigmatizing ways. So we used one frame that we called uncertainty normalizing, which is meant to really attack any amount of skepticism that comes from the fact that the information, scientific information, might be incomplete, although we still believe with the best evidence that these behaviors are really warranted. But the main thing we wanted to look at was this destigmatizing message in the middle, and you can read that for yourself, but it's really specifically aimed at conquering this misattribution bias that blames victims for a health condition. So this was also a time where there was a lot of negative stereotyping language around, the coronavirus being the China virus, et cetera. And we really wanted to tackle that type of thinking and to emphasize to people that, in fact, it's nobody's fault, but everyone's responsibility. And then we tested these 2 messaging strategies against what we thought were more conventional messages that were around the airwaves already, that were meant to sort of promote optimism or to affirm pro-social values. So we compared these 4 different messages. And the way we measured their efficacy was we conducted a social media campaign on Facebook and Instagram, where we tried to get people to basically click onto these messages and to engage in what we call a call to action. And we measured the clicks and how much engagement, so-called, did each of these messages get, both in terms of clicks, as well as did they click on either for more information, or did they actually click to take a pledge to do the behavior, like pledging to always wear a mask, for example. And what we found in this study, interestingly, is that by all of these social media metrics, which I'm not going to get into because I'm actually, frankly, not an expert in social media research, But looking at basic metrics that are widely used in social media research, like looking at clicks and pledges, we did find that the two messages, and in particular, the destigmatizing message, drove the most engagement, meaning it was most engaging, it got the most clicks and click-throughs and call to action behavior from respondents. Then those typical sort of hope promoting or pro-social value messages. And the uncertainty normalizing message also performed very well. These were the top two performers in our study. So this experimental study was very encouraging to us that perhaps these kinds of messages are more engaging, and maybe this is a way to promote destigmatized attitudes about this particular condition. So with that, we designed a second study, which we just ran, and we don't have all the data in, and we're still analyzing this, but we took a different approach, now focused on I think our real interest, which is lung cancer risk. Conducted another study on Facebook to look at this, and the behaviors you can see here were more screening for lung cancer with low-dose CT, smoking cessation, and then we also wanted to test fundraising as another. This was conducted during Lung Cancer Awareness Month. We wanted to see if we can gauge the public just to be interested enough to donate to the cause, for lung cancer control, prevention, screening, and control. We coupled these behavioral messages with, again, different framing messages, destigmatizing, as you can see. The ALA also has a destigmatizing messages they've already used in ads. Anyone with lungs can get lung cancer, so we wanted to sort of test those. And then a conventional message, which is lung cancer is a leading cause of death. And here we're also using a metric of call to action to see if people would click on to either learn more about screening or donate or click on to the quit line. And so these were the outcomes. And all I can say about this is that we just got the data in, and we're starting to analyze this, and we'll have more results in the future. But what I wanted to really emphasize to close this discussion is that we think that this work and work of others is contributing now to developing an evidence base around how we can actually create and implement and disseminate messages that might destigmatize diseases such as lung cancer. This is very preliminary. We think much more work is needed to develop new strategies. These aren't the only messages or strategies one could think of that might be effective for this purpose, but we think that they're promising. There's other potential theory-based approaches that people have talked about or started to talk about, for example, emphasizing the urgency of this problem, trying to foster empathy, and again, appealing to moral values, and trying to appeal to people's ability to be flexible, more resilient, and perhaps sort of tapping these types of important elements and values might be another other effective strategies. But I just want to end by coming somewhat full circle back to the problem of stigma, and to say that no matter how much evidence we might have either for or against different strategies for destigmatizing lung cancer and other conditions such as this, in the end, this is not even an empirical problem. This is, again, it's a moral problem and really something that we have to be committed to engaging in, this whole task of destigmatizing. It's the right thing to do no matter what evidence that we may or may not have about this problem. And that sometimes while we're in the position now of waiting for evidence, that's not an excuse to do nothing about this. And we know that sometimes attitude change has to follow behavior change. And this has been true for many things outside of healthcare when you think about stigmatization and discrimination and injustice in our society. And going back to this figure that Liz put forth, you'll remember there was a box starting from the left. Well, sometimes even though we think that we need to start from attitudes and then go to changing stereotypes, reducing them, changing attributions, and lowering discrimination, sometimes we have to start on the right side or with other of these things and first try to do the right thing from a moral standpoint, and then lower stereotypes and more positive attitudes will follow. And sometimes the causal arrow goes that way. And so we believe that while we're waiting for better evidence, we still need to act to try to reduce stigma, not only in lung cancer, but for other healthcare conditions. So I just want to stop there. I think that this is all the slides that we have to present. And we have a few minutes for discussion, and I'll turn it back over to Liz, and I'll just stop sharing here at this point.
Great. Thank you so much, Paul. Thank you, Leo. Thank you, Liz. Fantastic presentation. And again, great to have you all. So at this point, we're going to look into the chat. We have a couple questions, some comments. So just going to pull those up. Some of the comments were made as you were speaking. So, just keep that in context as I kind of read through those. And then basically, again, if anyone has any questions, we just encourage you now to put them in the chat as we have our presenters here to answer those for you. So looking at the chat, again, this is from Andrea Barodi-Kitts. Thank you, Andrea, for your comments. We appreciate that. However, though effective, it stigmatizes people who smoke and in the population that continues to smoke. Low SES disadvantage. Now, it's actually counterproductive and may lead individuals to not want to quit. Research has shown that hope and empathy works better. I would suggest we use people first language. A person who smokes is not a smoker. A person who used to smoke, not a former smoker. And SDM association may be due to the smoking cessation portion of the SDM discussion. So the question is, after those comments, thank you again, Andrea. Addiction is also stigmatized. How do you posture tobacco use as an addiction without adding to the stigma?
Yeah, those are all really great points. And first of all, just to sort of amplify what Andrea said, she made so many other great points there in that chat. And, getting back to also Liz's presentation early on, I think the problem is somewhat self-inflicted. It's a self-inflicted wound, this sort of risk factor sort of thinking that the medical profession and research has contributed to, because every time we find a risk factor like smoking, it's a very short leap to blaming people who engage in that risk factor for what happens to them. And so it's not as if people are walking around like with these evil thoughts, but we're sort of doing that in some, we meaning researchers and the medical profession, when we make these links and we're saying, oh, you have to stop smoking because look at these studies that show what happens. And sorry about that. Somebody must be at the door. My dog's going crazy. But so I think in some sense, it's this sort of risk factor equals personal responsibility link that we're somewhat responsible for as a medical profession. But we need to get people to decouple that and to somehow engage in more flexible thinking that recognizes that these risks don't say something about a person's moral worth, or they're not simply to blame. The story is much more complicated than that. And there's elements of randomness and lots of other things that contribute to what happens to people in terms of their health. But so I think that these are all great points, and we want to really shift shift thinking away from this sort of attribution. And I think I need to go off, mute myself, and have someone else take over here for a second.
Yeah,
hold on.
I totally agree. I want to follow up on the point about decoupling. I think that what social psychological theory has really shown us is that if we can kind of break down those associative bonds between group membership, quality characteristic, and stereotypes, or things that are devalued in our society, we can move to a place of actually changing an attitude. And so if we can displace some of that shame and blame, or think of counter stereotypical exemplars and present those, we can change the public perception and discourse. I also think that providing opportunities to develop empathy and social cohesion is really important as well. And being able to create kind of lasting mitigation of stigma. And I really like the question of how do we, if we, acknowledge that tobacco use is a substance use disorder or an addiction, how do we not then add additional stigma? And I think that's a really interesting point, because we know that stigma is additive and stigma is intersectional. And we all have multiple facets of our identity. So we can have multiple facets of ourselves that can be stigmatized simultaneously. So I think it gets back again to that decoupling and breaking down those associative bonds that we have. And I think that we have to, unfortunately, I think I agree completely with Paul, we have a moral obligation to begin, but we have to work from kind of what we're observing and moving backward from there. So we're already observing the disparities and the discriminatory behavior. So we need to address the attributions and explanations people are making for that behavior and work backwards to ultimately changing public perceptions and attitudes, which is going to take a really long time. And through that process of really working on being mindful about what is informing our attributions, are we relying on cognitive shortcuts and biases, and being aware that when we're strapped for time, resources, things like that, which oftentimes in healthcare we absolutely are, there's high degrees of uncertainty. Fear leads to heightened stigmatization and blaming. Those are the times we need to be able to identify, this is a situation in which I may not be making a fair attribution. So take a beat, reevaluate and give yourself opportunity to create empathy.
One other thing I wanted to quickly add before my dog interrupted us is that Andrea's question about addiction, adding to the stigma and being stigmatized. I think what we're trying to get at is even for addiction, this is sort of a next meta level of flexibility that's required. So again, if it's true that addiction is stigmatized, but I think we need to yet transcend that with added flexibility to sort of get people to realize that addiction itself is not someone's fault, and that it's a complex real condition that we really need to kind of address in the same way, to sort of rise above that with added flexibility in our thinking. So
Great.
Yeah.
Thank you. Well, go ahead, Leo. Did you want to respond?
I was just going to add that, I think it also goes back when, I know there's some clinicians in the audience, when we think about clinical interactions with physicians and other healthcare providers and their patients, it goes back to the importance of therapeutic alliance, right? And we're talking about empathy. And if you build those relationships and that alliance, and you can use evidence-based, non-judgmental approaches like motivational interviewing and other techniques when you're that are from the substance use disorder world, and evidence-based treatment modalities that can contribute towards building that alliance and building that empathy between providers and patients that can help with the destigmatizing approach as well.
So I think one other thing that's important to recognize is that no single approach is going to hit all levels of intervention that are needed. So this kind of the broad public health messaging is more a targeted intervention for public perceptions or those larger attitudes, but there needs to be multiple levels of intervention, so stigma is expressed at interpersonal levels as well as embedded within really big social structures. And so we need to, while I think these kinds of messages and kind of ideals, so, lack of do not other, create opportunities for empathy and social cohesion have to be embedded within all of those different approaches. We need a targeted approach for the different ways in which stigma is expressed and experienced. So that's just another, this is not the approach to target all kinds of stigma, all stigma at all levels, but it's at least an avenue for a way that stigma is expressed.
Thank you so much. That was actually a perfect segue into our next question, which is, do you see a place for similar theory-based messaging related to radon and lung cancer? For example, any home can have radon. It's the environment and no one's fault. Test your home.
Yeah, that's a great question. So we have worked on some radon messaging campaigns on social media and more sort of in our policy work as well. And I think that is an important sort of avenue. I think the thing to be careful with that we've seen come up in slightly different contexts, which often comes up actually in the lung cancer community as it relates to patients with genetic variants which predispose them to lung cancer, where sometimes you have sort of the statements made of I didn't smoke, so but I got lung cancer. And so I think, going back to unintended consequences, I think we also want to be careful with our radon messaging of, I think it's more an emphasis on radon is another risk factor for lung cancer rather than, you didn't smoke, so you didn't deserve to get lung cancer. You had radon, high levels of radon in your home. So
you don't want it to become like an identity qualifier, like I am someone who didn't smoke, and so we don't want to create kind of an unintentional hierarchy among people. That the bottom line is that we would ideally want to get to a place in which the attitude is that nobody, regardless of the antecedent, should suffer from a life-threatening illness, regardless of what risk factors or behaviors they may have engaged in. So we don't want to kind of pit risk factors against one another, because that could create other unintentional harmful associations.
Wonderful. Thank you all. And I apologize. We have had some great discussion, so we don't necessarily have time for all the questions. But as I mentioned in the beginning, we will take all these questions, we will save the chat, and we will develop a question and answer document. So we will answer your questions. And when I say we, that means all our presenters. We'll send it out to them. And then when we send out the slide deck and a link to the SurveyMonkey and a YouTube link, we will include this question and answer document as well. So I'd like to, at this point, thank you all for joining us. We appreciate the gift of your time and being part of our webinar today. A special thank you again to our presenters, to Paul, Liz, and Leo. Terrific job. Thank you, Mary, my colleague, for handling all the tech with this webinar. We so appreciate that. And again, thank you all for joining us today, and we hope to see you again on our next webinar, which we are planning for May. So hoping you'll all join us then. So thank you so much and have a great day. Take care, everyone.